So we are lucky to have Andrew Chang with us, and he will set the ball rolling and tell us about achieving sustained release control in NAMD and the rationale for a higher molar dose of aflibercept.
Thank you very much, Dr. Verma, and congratulations on an absolutely fantastic meeting. So let's just go to, here we go. Now, this is the agenda for today. I'm going to talk about, generally about aflibercept, including 2 milligrams, and touch on 8 milligrams. Kelvin, my co-panelist, will talk also about the PULSAR trial and its relevance in clinical practice. I will talk about early experience that we have had with aflibercept 8 milligrams in Australia. Vorapon will share with us insights into PCV, and then we'll also cover some cases. So let's get going. These are my financial disclosures. There is an abundance of experience with 2 milligram aflibercept. The results that we saw in the randomized clinical trials have been consistently replicated in the real world. It is a reliable, safe medication. It's very well tolerated, and we know how it behaves in our patients. In the real world, we have evolved in our treatment paradigms, in our regimens, and so we adopt a treat and extend approach, and in this study, the AIOS study, we were able to achieve robust vision gains whilst maintaining intervals up to 16 weeks. So in the real world, we have also been able to replicate those results that we saw in clinical trials. We have prospective clinical trials as well as real-world evidence. So we have now a decade where aflibercept has been, I would say, our foundation medication. 84 million doses, more than 12 million patient years, a decade of experience, and also we have used aflibercept 2 milligrams in a broad range of indications. But despite this, there are still some unmet needs. So let's talk about what these needs are. You know, in your practices, these are major points that we are challenged with. Time burden, our clinics are at capacity. Financial burden also for patients with out-of-pocket costs. And for the carers, there are also issues with burden, not only in wet AMD, as we will be covering today, but also diabetic macular edema. Is this going to settle? That is the demand going to resolve? It is not. It's going to continue to exponentially increase. Here we can see 113 million people in Asia will have AMD by 2050. And if you ask the patients, they are still going to want a longer time between treatments, but they also demand that they will not lose the effectiveness of medication, and vision is important. When we look at our practices, patient adherence remains a key challenge, and you can see here from 2016 to 2022, it continues to be a major challenge. So, despite effective therapies that we have with aflibercept 2 milligrams, there are challenges where we will need greater and longer lasting control, and that is, put simply, sustained disease control. So let's go on to now how we could potentially achieve this. Firstly, the molecule of aflibercept is ideally suited for durable VEGF suppression. high potency, high binding affinity, multiple molecular targets we can see here. But we will talk now more about new concepts, that is molar dose and ocular clearance. We know that aflibercept targets VEGF and that VEGF continues to be the master regulator of disease pathology by managing inflammation, neovascularization. Now, these two new concepts that I want to just take you through now, molar dose and ocular clearance. So aflibercept 8 milligrams provides 4-fold higher molar dose. And what this means also is that there can be a 34% slower ocular clearance when compared with 2 milligrams. So the modelling shows us that if we have 34% slower ocular clearance, that this has a potential in our patients to provide 6 to 9 week longer treatment intervals. So in your clinics, what does this actually mean? When we look at the distribution of patients who are under our care, we have those towards one end, that is, as you look at the graph, the left-hand side, higher treatment burden cases. These are cases that come to see us every month, and even with that, we have difficulty controlling their disease. And on the other side, another peak which has lower treatment burden. So if we had a longer acting agent, this is what we could potentially do. We could shift the curve over to the right, reduce the number of patients who require higher treatment burden, and that way we would be able to manage our capacity in clinics, but also reduce the burden for patients. What about those patients that are already relatively well controlled? They may be already in your clinics on 8 weekly intervals. Well, we could shift them also to the right up to 16, 20 weeks, and this would be a very significant help to how our patients are managed in our clinics and also how we run our clinics. So sustained disease control will therefore help us to address unmet needs, and the big challenge is high treatment burden. With this also, we want a safety profile consistent with aflibercept 2 milligrams.